Normal labor. So, labor is a process by which the viable fetus at the end of the 20th week or more is expelled or is going to be expelled from the uterus. Delivery means actual birth of the fetus. The following criteria should be present to call it the normal labor. Spontaneous expulsion of the single mature fetus presented by the vertex through the birth canal within a reasonable time, not less than 3 hours or more than 18 hours, without the complication to the mother or the fetus. Cause of the onset of labor. It is unknown, but the following theories were postulated. One is the hormonal factor and another one is the mechanical factor. Hormonal factor, estrogen theory. During the pregnancy, most of the estrogens are present in a binding form. During the last trimester, more free estrogens appear, increasing the excitability of the myometrium and the prostaglandin synthesis. Progesterone withdrawal theory. Before labor, there is a drop in the progesterone synthesis, leading to the predominance of the excitatory action of the estrogen. Prostaglandin theory. Prostaglandin E2 and F2 alpha. They are powerful stimulators of the uterine muscle activity. PGF2 alpha was found to be increased in the maternal and the fetal blood as well as the amniotic fluid late in the pregnancy and during the labor. Oxytocin theory. Although oxytocin is a powerful stimulator of the uterine contraction, its natural role in the onset of labor is doubtful. The secretion of the oxytocin enzyme from the placenta is decreased near term due to the placental ischemia, leading to the predominance of the oxytocin section. Hormonal factors. Fetal cortisol theory. Increased cortisol production from the fetal adrenal gland before the labor may influence its onset by increasing the estrogen production from the placenta. Mechanical factors. Uterine distension theory. Like any hollow organ in the body, when the uterus is distended to the certain limit, it starts to contract to evacuate its contents. This explains the preterm labor in case of multiple pregnancy and the polyhydramnios. Stretch the lower uterine segment by the presenting part near the term. Clinical picture of the labor. Predominant stage. The following clinical manifestation may occur in the last weeks of pregnancy. Shelving. It is falling forward of the uterus fundus, making the upper abdomen look like a shelf during the standing position. This is due to the engagement of the head, which brings the fetus perpendicular to the pelvic inlet in the direction of the pelvic axis. Lightening. It is a relief of the upper abdominal pressure. Symptoms as dyspnea, dyspepsia, and the palpitation due to the increased descent in the fundal level after the engagement of the head and increasing shelving of the uterus. Clinical picture of a labor. The pelvic pressure symptoms. With the engagement of the presenting part, the following symptoms may occur, that is, increasing frequency of the micturition, increasing rectal tenesmus, and difficulty in walking. There will be increased vaginal discharge and false labor pain too. Here we can follow the differentiation between the true labor pain and the false labor pain. True labor pain, this is regular. False labor pain, irregular. They increase progressively in frequency, duration, and intensity, while in false labor pain they do not. The pain is felt in the abdomen and radiating to back. Pain is felt mainly in the abdomen. Progressive dilation and the evacuation of the cervix. No effect will be felt in the cervix. Membranes are bulging during the contraction. No bulging of the membrane. They are not relieved by the antispasmodics or the sedatives. False labor pain can be relieved by the antispasmodics and the sedative. Onset of labor. It is characterized by the true labor pain. They show that is increased. It is expelled cervical mucus plugged into with the blood from the ruptured small vessel as a result of separation of the membrane from the lower uterine segment. The labor is usually starts several hours to few days after the show. Dilation of a cervix. A closed cervix is a reliable sign that labor has not begun. It is multigravity. In the multigravity, the cervix may admit the tip of the finger before the onset of labor. Formation of a bag of 4 waters. It bulges through the cervix and becomes tense during the uterine contraction. First stage. It is a stage of the cervical dilation. This starts with the onset of a true labor pain and ends with the full dilation of a cervix 10 cm in the diameter. It takes about 10 to 14 hours in the primigravida and about 6 to 8 hours in the multipara. Stages of the labor. The third stage, it is the stage of expulsion of the placenta and the membranes. Its duration is about 10 to 20 minutes in both primary and the multipara. Stages of the labor. The fourth stage, it is the stage of early recovery. It begins immediately after the expulsion of the placenta on the membrane and lasts for 1 hour, during which the careful observation for the patient, particularly for the signs of the postpartum hemorrhage, is essential. Routine uterine massage is usually done every 50 minutes during this period. In the first stage, the process of the cervical dilation is due to the contraction and the retraction of the uterine musculature. Mechanical pressure by the foreback of water if membrane still intact, or the presenting part if they are ruptured. This in turn will release the more prostaglandin, which is stimulate the uterine contraction and the cervical effacement. Softness of the cervix, which has occurred during the pregnancy, facilitates the dilation and the effacement of the cervix. And the mechanism of the cervical dilation in the primigravidas, the cervical canal dilates from above downwards, from the internal OS downwards to the external OS. So its length shortly gradually from more than 2 cm to the thin rim of the few millimeter, continues with the lower uterine segment. This process is called effacement and expressed in the percentage. So when we say effacement is 70%, it means that the 70% of the cervical canal has been taken up. Cervical dilation. Dilation of the cervix, external OS, stops after the complete effacement of the cervix. In multigravida, the effacement and the dilation occur simultaneously. In normal presentation and the position, the head is applied well to the lower uterine segment, dividing the amniotic sac by the girdle of contact into the hind waters above it containing the fetus and the fore waters below it. This reduces the pressure in the fore water, preventing early rupture of the membrane. After full dilation of the cervix, the hind fore water become one sac with the increased pressure in the bag of fore waters, leading to its rupture. First stage. In the first stage, the cervical canal dilates from above downwards, from the internal OS downwards to the external OS. So its length shorts gradually from more than 2 cm to the thin rim of the few millimeter, continuous with the lower uterine segment. This process is called effacement and expressed in the percentage. While speaking about the phases of the cervical dilation, the latent phase, this is the first 3 cm of the cervical dilation, which is slow, takes about 8 hours in the nullipare and 4 hours in the multipare. And the active phase, it has 3 components: acceleration phase, maximum slope, and the deceleration phase. The phase of maximum slope is the most detectable, and the 2 other phases are of short duration and can be detected only by the frequent vaginal examination. The normal rate of the cervical dilation in the active phase is 1.2 cm per hour in primigravidae and 1.5 cm per hour in the multipare. If the rate is less than 1 cm per hour, it is considered prolonged descent. It is continuous throughout the labor, particularly during the second stage, and they are caused by uterine contraction and the retraction. Engagement. The head normally engages in the oblique or transverse diameter of the inlet. Increased flexion as the Atlanta-occipital joint is nearer to the occiput than the incipit. Increased flexion of the head occurs when it meets the pelvic floor, according to the lever theory. Internal rotation. The rule is that the part of the fetus meets the pelvic floor first, will rotate anteriorly, so that its movement is in the direction of the levator ani muscle, the main muscle of the pelvic floor, downward, forward, and inward. In normal labor, the occiput, which meets the pelvic floor, first rotates anteriorly 1/8 per cycle. And the extension. The suboccipital region lies under the symphysis. Then by the head extension, the vertex, forehead, and the face come out successively. The head is acted upon 2 forces: the uterine contraction acting downward and forward, the pelvic floor resistance acting upward and the forward. Downward, forward, upward, forward. So the net result is forward direction, that is the extension of the head. Restitution. After the delivery, the head rotates 1/8 of a circle in the opposite direction of the internal rotation to under the twist produced by it. External rotation. The shoulder enters the pelvis in the opposite oblique diameter to be to the previously passed by the head. When the anterior shoulder meets the pelvic floor, it rotates anteriorly 1 by 8 of the circle. This movement is transmitted to the head so that it rotates the 1 by 8 of a circle in the same direction of the restitution. Delivery of the shoulder and the body. The anterior shoulder hinges below the symphysis pubis with a continuous descent. The posterior shoulder is delivered first by lateral flexion of the spines, followed by the anterior shoulder, then the body. After the delivery of the fetus, the uterus continues to contract and retract as the placenta is inelastic. It starts to separate through the spongiosal layer by one of the following mechanisms. Sklets mechanism 80%. The central area of the placenta separates the first and the placenta is delivered like an inverted umbrella so that the fetus surface appears first, followed by the membrane containing the small retroplacental clot. There is a less blood loss and less liability for the retention of the fragmenta. Duncan's mechanism, which is remaining 20%, the lower edge of the placenta separates first and placenta is delivered sideways. There is more liability of the bleeding and the retained fragments. Third stage, placental separation, placental descent and the placental expulsion occurs here. Physiological effects of labor. In the first stage, the mother have the minimal effects. In the second stage, the temperature slight rise to the 37.5 degrees Celsius and the pulse increase up to 100 per minute, and the blood pressure, the systolic blood pressure may rise slightly due to pain, anxiety and stress. Edema and the congestion of the conjunctiva may also occur, and the mother may have the minor injuries to the birth canal, and the perineum may occur particularly in the female gravidas. In the third stage, the blood loss from the placental site is 100 to 200 ml, and from the laceration or the episiotomy is 100 ml, so that the total average blood loss in the normal labor is 250 ml. Molding. The physiological gradual opening of the ball bones as the skull is compressed during its passage in the birth canal. One parietal bone overlaps in the other, and both overlap the occipital and the frontal bone, so the fontanelles are no more detectable. It is of the good value in reducing the skull diameter, but severe or rapid molding is dangerous and may cause the intracranial hemorrhage. Caput sacchadenum on the fetus. It is a soft swelling of the most dependent part of the fetal head, occurs in the prolonged labor, before full cervical dilation and after the rupture of the membrane. It is due to the obstruction of the venous return from the lower part of the scalp by the cervical vein. Large caput may obscure the sutures and fontanelles, making the identification of the position difficult. This can be overcome by the palpation of the ear. This gives an impression that the head is lower than its true level. The artificial caput sacchadenum chignone. This is induced during the vacuum extraction. Caput sacchadenum disappears spontaneously within hours to days of birth. As it is a vital manifestation, so it is not detected in the intrauterine fetal death. The presence of caput indicates the fetus was living during the labor. Labor was prolonged and difficult. The attitude of the fetal head during the labor can be expected as the caput. This is present in the most dependent part of it.